Hello and welcome to Finding Relief Advances in Hand and Wrist Treatments. We have such a wonderful event for you today. Thank you so much for joining us. We do have a pretty large anticipated audience, so we do want to allow time for everybody to kind of funnel in, settle in with this time frame. We strongly encourage you to grab your lunch, your coffee, tea, relax from the comfort of home, because that's what it's all about here today. Please note that the best way to view today's event is going to be through either Google Chrome or Firefox. You want to ensure that it is the most updated browser. And if you're having any kind of technical issues, please send us a chat message. However, I do strongly encourage you to log out and log back in using one of those browsers if there's an issue. During this time, I'd like to introduce myself. My name is Deanna Makota, and I'm a caregiver here at the Cleveland Clinic and your host for today, which means I'm just going to be introducing our presenters and moderating our Q&A segment, which is going to stick around at the end of the presentation, so please stick around for that. I would like to draw attention to the Q&A box feature that you will see at the right-hand side of your screen. This is where you can submit some questions that you might have for our presenters during their presentations, as well as some helpful handouts that you can download and read at your convenience, including some of the information that you did see in our waiting room. Today's event is brought to you in partnership by the Cleveland Clinic and the Arthritis Foundation. And just a little bit about both of us. Here at the Cleveland Clinic, our orthopedic and sports medicine team is dedicated to helping you regain mobility, reduce pain, and enhance your overall quality of life. Our experts are here to provide the advanced treatment options and experience you need to get back to being you. And a little bit about our partners at the Arthritis Foundation. The Arthritis Foundation is where you'll find help, hope, and a caring community who understands what you are going through. Turn to the Arthritis Foundation for trusted information, tips, and tools, plus a way to connect with those who face similar challenges. Again, at this time, I would like to formally welcome you to Finding Relief Advances in Hand and Wrist Treatments. We have such a wonderful event for you today with two great specialists, and I would like to begin by introducing our first speaker, Dr. Nicholas Satariano. Dr. Satariano was born and raised in Northeastern Ohio and graduated summa cum laude from The Ohio State University, went on and attended Case Western Reserve University School of Medicine, where he was awarded his medical doctorate with honors and distinction in research. He completed his orthopedic surgery residency at the University of California, San Francisco, and went on to the University of Cincinnati to complete his fellowship for specialized training in hand surgery. Dr. Satariano treats common problems such as carpal tunnel syndrome, trigger finger, thumb arthritis, ganglion cysts, and DECRA veins. He takes care of all types of hand injuries, including wrist and finger fractures, as well as tendon and nerve lacerations, and has a particular interest in Dupuytren's disease, where he offers in-office procedures and surgical management in the operating room. His expertise ranges from evaluating small lumps and bumps to undertaking major hand reconstructions. Dr. Satariano sees patients at the Akron General Physician Office Building in downtown Akron and the Akron General Health and Wellness Facility in Bath, and new patients are, of course, welcome. What an honor to have you here, Dr. Satariano, such a fantastic bio. We want to thank you so much for your time, and without further ado, please take it away.
Okay, perfect. Good afternoon, everyone. Thank you for that introduction. Okay, I'll get to my slides here. So this is going to be common hand problems, as told by your hand surgeon. That's me. So the three big ones we're going to hit today: carpal tunnel, trigger finger, and thumb arthritis. All very common. We're going to start with carpal tunnel syndrome. How many of you out there have had some hand numbness? Sometimes this is the tips of the fingers, sometimes it's the whole finger. It tends to be maybe more the thumb side, index, middle finger. Some people wake up at night and they have to shake their hands out, right? They can't really feel them. Sometimes they have to leave them over the side of the bed. Sometimes they're numb when they're going to the bathroom in the middle of the night. Sometimes people wake up with numb hands. Some people will say, I've been dropping things. Turns out it's hard to hold small objects. You can't feel them, okay? Other people will say, I just feel like I have this dull ache in my hands. Sometimes it goes to my finger, sometimes it's right in the middle of my hand, and it's really tough because it's always there. If you're experiencing any of these, you may have carpal tunnel syndrome. So the next most important question, what actually is it? So the textbook definition, compression of the median nerve in the carpal tunnel. We're going to break that down piece by piece. So first off, it's compression of a nerve. Let's look at nerves. So it turns out we all have nerves. It's important to us interacting with the world, okay? So let's do a little nerve whirlwind. Let's go to the whiteboard. We have a nervous system, and it starts right at the head with the brain, okay? All the nerves start up there. When they leave the brain, they go into the spinal cord, and then at each level, the nerves come out of the spinal cord, and they go down to the tips of the fingers, okay? So when you feel something, let's say you put your hand on the hot stove, that sensation from your fingertip up the nerves in your arm, through your spinal cord, up to your brain, and tells you, hey, that's really hot. And then your brain reacts by sending a signal back down through the spinal cord, back down the nerves to the muscles and says, pull your hand away, okay? If at any point there is a problem on this highway where that signal can't get there, you start to have symptoms, okay? So what do nerves do? I already alluded to this a little bit, but they provide sensory information, so your sensation. They tell you about pain, and they can also tell you about temperature. So if any of the nerves are compressed or not firing well, you can have problems with your sensation, or you can have pain. How do nerves work? This is kind of a fun one. So this is a blown up image of a nerve, like in a microscope. And there's all these little fibers, and each fiber is surrounded by a sheath to insulate it. This looks very similar to your typical electrical cable, okay? Electrical cable, it's got fibers, it has insulation around each of those, it has bundles. Now, just like an electrical cable, if you damage the outside of the electrical cable, you're gonna damage some of those fibers, you're not gonna get the full signal. It's the same way with a nerve. If you're pushing on the nerve, or there's an injury to the insulation around the fibers, the nerves aren't going to work as well. So what actually is it? Okay, we've covered nerves. Now let's cover carpal tunnel. What is the carpal tunnel? Back to the whiteboard. Everybody, hand up, okay? Palm facing your face. Okay, it's your right hand, palm facing your face. There's the median nerve, that yellow stripe. It runs right down the pipe, okay? And it feeds the sensation to the red part of the hand there. Thumb, index, middle, and the radial side of the ring finger. That's the sensation you're getting from the median nerve. The little finger, the pinky finger, that's coming from something else. We're not going to talk about that today. So the median nerve runs right down the pipe. These are the fingers it innervates. So this is the carpal tunnel. And there's a ligament that goes across the nerve and protects it right at your wrist crease, okay? That is actually what the carpal tunnel is. So when you have compression of the median nerve in the carpal tunnel, it's right at that wrist crease where that ligament gets pretty thick, and then it presses on the nerve. And when you have compression there, that's when the nerve is no longer firing as well. Those fibers can't fire as well if they're being very tightly compressed. So what actually is it? You got it. Good work. We learned about nerves and the carpal tunnel. Who gets this? Diabetics, people with rheumatoid arthritis, people with thyroid disease, more often hypothyroid. Obesity increases the risk, and smoking, because smoking does all the bad things. The other interesting subset of people who are prone to getting carpal tunnel are pregnant moms. It can be either during pregnancy or after pregnancy, and has to do with the increase in hormones and the increased swelling in the carpal tunnel. And then classically, people who do several repetitive jobs. So for example, typing, or as a hairstylist, those patients also tend to get carpal tunnel more common in the general public. Okay, we covered this as well. What does it feel like? We just talked about it. It's numbness, and it's more often in those radial digits. Remember I showed you that map of what the median nerve innervates. So radial digits, thumb, index, the middle finger. Waking up at night with this numbness. Some people, their hands go numb during the day when they're driving a car or using a tool or something. Okay, so we know what it is, who gets it, what it feels like, how can we treat it? There are three main buckets. First up, braces. So when you sleep at night, most of us slept for 9 months in the womb, okay? So we're all used to sleeping in a little bit of a fetal position with our wrists flexed. That flexion all night long decreases the space in the carpal tunnel. And so what I prescribe is a cock-up wrist brace at night, which holds the wrist in extension and lets that nerve breathe all night long. Sometimes people wake up the next day and they have much better sensation all day long. Third option is an injection, or sorry, the second option is an injection. And with this, I try to put a cortisone shot directly into the carpal tunnel. So I have to be very careful because I need to get right next to the nerve, but I don't want to hit the nerve, or trust me, you will let me know. The steroid decreases some of the inflammation in there, and it creates some more space for the nerve. And that can help. If you have mild or moderate disease, that can help. However, if you have severe disease, we tend to recommend surgery. Carpal tunnel surgery is the most common surgery I do. Again, your right hand is up in the air, palm facing you. So you see that ligament in the carpal tunnel, and you see the median nerve going underneath it. I make a small incision directly over top of that ligament. I spread right down. I look at it, and with my scissors, I just go chomp, 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 open up the ligament, and the nerve can breathe again. It's like opening the top of the tunnel. I just leave it open. I do close the skin, and it looks something like this. This is 2 weeks after, so you can see pretty small incision. It's an outpatient surgery. It takes me about 15 minutes. Soft dressing, and I would say 95% of my patients are very happy. And this is kind of what it looks like at about 6 weeks. Okay, carpal tunnel, check mark. Let's go to trigger finger. Does anybody out there have pain when they're making a fist, specifically when they make a tight fist with those fingers? And it feels like right here, right across the heads, at the base of the fingers, it feels like something doesn't feel right, a little bit of pain. Some people describe clicking, where they can almost feel a hitch when they're bringing their fingers down, or sometimes when they try to open their fingers back up, they feel a little hitch. Some people, they'll actually say, I make a fist, and I literally can't bring my finger back up. It actually sticks like this, and I use my other hand to open it back up. And obviously, it hurts when you do that. If you're having any of these symptoms, you may have a trigger finger. The next most important question, what actually is it? We'll go back to the textbook. Stenosing tenosynovitis of the flexor tendon sheath. Another mouthful, which means we should go back to the whiteboard. Okay, flexor tendons. So if you're looking at your forearm, palm up, you see you got some muscles here, okay? And you can feel them. Now, if you make a tight fist, you can feel those muscles contract in the forearm, and it brings the fingers down. So the muscles start in the forearm, and the tendons go all the way out to the fingertips. When you contract that muscle, it pulls the fingers all the way down. Okay, so that's how flexor tendons work. Now, if we zoom in on the hand, I'll show you, here's the tendons again. They're coming up, they're on the palm side, and they're coming right across the palm, and then they go all the way out to the fingertips. So when you pull on the tendons, tips of the fingers come all the way down. Now, the important structure here is the flexor sheath, and this allows the tendons to be lubricated and slide really, really well. We want those tendons gliding without any friction so we can make a tight fist, okay? So the tendons run through a flexor tendon sheath. This is the side view of the finger, and then those tendons. And again, I marked out, this is the flexor sheath, which is comprised of a bunch of pulleys. And so the tendons run through each pulley. The pulleys keep them right against the bone, and it keeps them nice and lubricated and protected so that they can slide. What happens to the trigger finger is this first pulley, the A1 pulley of the flexor sheath, gets really thick. And then all of a sudden, the tendon can't glide as well anymore. So it's like a big semi-truck on the highway, and it goes through a tunnel that's too tight. What's going to happen? Right? Mirrors, they're getting knocked off. The roof, it's getting all scraped up. Sometimes the truck may even get stuck in the tunnel. That's just like your finger. Your finger gets stuck down like this. That's like the tendon getting stuck in that tunnel. So like we said, stenosing tenosynovitis of the flexor tendon sheath, and this is exactly what it looks like. You have the red tendon, you have the pulley that's thickened now, that tendon can't glide as well, and it forms a little nodule. And you can imagine as that nodule gets stuck on either side of the sheath, on either side of that tunnel, that finger is going to get locked down, and you're going to feel it click as it goes through back and forth. Check mark. Who gets trigger finger? Females, you're just unlucky. You get it more often. Age greater than 50, this can be a little bit of a wear and tear. You know, the more you use your hands, you can develop a little bit of scar tissue in that tunnel. Diabetics, rheumatoid arthritis again, and thyroid disease more often, hypothyroid. Check mark. How does it present? Just like we talked about. It's pain when making a fist, typically right across the knuckles here, and sometimes you feel the actual mechanical symptoms, the clicking and locking. Most interestingly, the ring finger is the most common here. How can we treat it? This time there are 4 buckets. So the first one is called suffering. And I only put this one up to say that this is not your heart or your lungs or a big open fracture, okay? People can have a trigger finger. It can be a little clicky, but if it does not bother you, you don't have to get it done. You can leave this alone. Again, this is entirely elective. And if you leave it alone, as long as you can keep moving it and it's not too stiff, even if you have a little bit of a click, if you want to leave it alone, completely okay. You're not going to do a significant amount of damage. So suffering, quotes, option, it does have a 0.0% success rate. So if you actually want to get it treated, we have to do something else. So that gets the frowny face. Next up are braces. So this is what the brace would look like. And again, it basically just stops the finger from flexing so that that nodule stops getting caught in the pulley and you stop having pain. Now the problem with this is, you can imagine if you wear a brace for 3 months, you're not going to have a trigger finger. Be great, but your finger also isn't going to move. It's going to be a very stiff finger, and that's going to be a bigger problem. So for that reason, I don't advise braces for real trigger fingers. That also gets the frowny face. Injections. I promise that I do have something to help you with, I promise. Injections are helpful. You can put a cortisone shot directly in that tunnel, and it's like greasing the wheels. That's that truck, the tunnel a bit easier. And 50% of people, they have an excellent response to an injection. But if an injection, so this gets happy face. This is that good. Now, if an injection doesn't work, then we're in the surgical realm. And for surgery, I make a longitudinal incision directly over that pulley. I spread right down at it, look at it, and then scissors, chomp, 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 open it up, and that tendon can glide very smoothly. So it's like right there. I make a longitudinal incision right along the red dotted line. This is the second most common surgery I do after carpal tunnel. You can see that's approximately what the incision looks like. It's outpatient, takes me about 15 minutes. And I do most of them wide awake, meaning I know up in pre-op, but in the surgery, you're awake. You can't feel anything. You don't have pain. But the reason I do that is so that after I release it, I can test it. And I can, okay, start making a fist. Let me see if it's clicking. Let me see if it's locking. And that's how I know I treated you. And it's pretty cool. Some people like to look at their tendons. Up dressing, move immediately. Greater than 95% of the people do excellent. And it gets the very high face. Okay, last but not least, thumb arthritis. We're almost there. Does anyone have pain, base of their thumb, kind of right where that guy's pushing in the picture? And it's worse with certain activities. It's kind of like an ache, an aching pain. Some people say, it's really hard for me to open jars, open doors. And they'll say, you know, I feel weak. And part of it is just, I don't feel like I have the same strength. Part of it is the pain is kind of limiting me. If you have any of these things, you may have some thumb arthritis. So what actually is thumb arthritis? It's basal joint arthritis at the base of the thumb, which means time for another anatomy lesson. Here's your hands. So this time it's the left hand, palm looking at you, okay? There's the thumb. This is the first metacarpal bone, so that's kind of deep under the meat of the thumb. And then this is the trapezium, one of the carpal bones. So this joint, where the first metacarpal meets the trapezium, is the basal joint. And you can see it's deep in your thumb there. So a typical joint looks like this. This is the basal joint again. And you have your first metacarpal, you have your trapezium. And I want you to see there's nice white cartilage. See how there's space? So cartilage works best when it's like 2 ice cubes. Okay, imagine 2 ice cubes. You're rubbing them against each other. There's like no friction. They can slide all day long. When you have arthritis, you've lost the cartilage. And now, instead of 2 ice cubes, now it's like 2 gravel, beat up rocks. And you're rubbing those against each other. That's not going to feel good. They're not going to slide very well. That's your bone on bone. That's what happens. No more cartilage. It's bone on bone, gravel on gravel. And you can see in this picture, you get some bone spurs, and the bone starts getting beat up. It looks like if I would zoom in specifically on the basal joint, you can see the bone gets kind of red. You don't see that nice, white, shiny cartilage here. And that's what's going to cause your pain. Check mark. Good work. Who gets it? Age greater than 60. So this is a wear and tear injury. If you have other bad arthritis, let's say you've had a knee replacement or a hip replacement, you're probably at increased risk of just getting more arthritis in your body, and your thumbs are very common. Ligamentous laxity, so people who are double jointed, sometimes they can have decreased stability of the joint, which over time can lead to arthritis. And then heavy laborers. If you've been using a jackhammer and swinging around a big mallet all of your life, you're at increased risk of having thumb arthritis, much more so than someone who types all day. Those people get carpal tunnel, so don't worry, they still get something. Okay, check mark. This presents the base of the thumb, kind of deep in the base of the thumb, worse with activities, worse with turning objects, and some weakness. How can we treat it? 4 buckets. We'll start with some medications. Now this can help with mild disease. I typically recommend Voltaren gel. It's a topical, non-steroidal anti-inflammatory, which you can rub in right around the base of the thumb. And then some people also find relief from something like meloxicam. It's a once daily non-steroidal anti-inflammatory, something similar to Alleviate. After that, most people start with a brace. This is called push metagrip brace. And it's great because it's not too big, it's not too bulky. It still allows you motion of the thumb, but it provides some extra support. And a lot of people, they'll work out in this, they'll do yard work in this, and it really helps. Third thing would be an injection. For this injection, I try to put that steroid directly into that basal joint. And although it doesn't give you new cartilage, it does decrease some of the inflammation associated with the bone-on-bone contact. And if injections work, I will inject you all the long day because we want to try to avoid a surgery here. Unlike a trigger surgery or a carpal tunnel surgery, which we're about to see, the first CMC surgery, the thumb arthritis surgery, is a more involved surgery, and it takes much longer to recover. So we try to avoid that surgery as long as possible. So lastly, surgery. This is an x-ray of the basal joint, which you can see right here. So this is your right hand with the back of your palm, the back of your hand face to face. And you can see this is the bone-on-bone arthritis there. You can see a little bone spur. So in the surgery, I make an incision over that, and I spread down, and I actually take out the bone that's grinding on the thumb. I take out the trapezium. Now some people say, well, you take out my trapezium, what's the thumb going to do? It's floating. What I do is I put an anchor into the base of the second metacarpal, and I tie it to the first. So I suspend it from the second metacarpal. And then for 6 weeks, you have to be in a splint, and you cannot load the thumb. I don't want you to move the thumb too much. You have to let your body create a big scar tissue ball right underneath the thumb. Because if you start using it too soon, that thumb is just going to come crashing down into the next bone, and then we're going to be exactly where we started. So that's why I say this is a larger surgery than a trigger or a carpal surgery. It takes about 2 hours. It's still outpatient. But for 6 weeks, you're not moving it too much. You're not definitely not doing any weight bearing. And it's usually until 3 months after people say, you know what, I finally got some of my motion back. And it takes a lot of rehab, but I finally got some of my motion back. I finally feel like my grip strength is better, and they don't have any pain, which is great. But I just have to really slow people down because this is a real surgery. Okay, carpal tunnel done, you're done, thumb arthritis done. Excellent work, we made it. This is the part of the talk where I get to have more fun, and I usually picture like kids or dogs, but I don't have either of them. So you get to see my family. Okay, the quiz is, do you know which one's me? I'll help. So that's me, bottom left. My little brother Chris also works at the Cleveland Clinic. He's a CRNA. My dad also works at the Cleveland Clinic. He's been an anesthesiologist for 36 years. And my little brother, Matt, is a medical student who rotates with the Cleveland Clinic. So that's all of us. I'd be remiss and show you mom too. She actually works in surgery, but not in the Cleveland Clinic system, so I don't get to work with her. I'm married. This is my wife. She's an eye surgeon. We like to cook. This is Thanksgiving. We also like to eat. And so we recently had National Cheesecake Day, which is July 30th, for anyone who doesn't know. So we had to celebrate by going to the Cheesecake Factory with our matching shirts. And Cherry Bliss, that was our favorite. And lastly, the next most important person in my life is my PA, Yurka. She's excellent. She is in the office with me. She works in surgery with me. And if you come to see us, you get to meet us both. Everybody, thank you so much. Hope this helped. And I see you at the hand session.
Wow, thank you so much. I really loved that presentation. I have to ask you, do you engage in any kind of interaction with people who aren't surgeons? I love it. I love your medical family.
I need to get out of my Venn diagram.
I love it. I love it. That was a fantastic presentation, and we are so fortunate. Many of the questions that we received upon registration, I think you nailed it during your presentation, but we really do appreciate it. And I know we're going to ask you some more questions coming up. So Dr. Satariano is going to go off screen for a little bit, but we do want to thank him so much for his presentation. That was fantastic. And we are going to actually welcome our next presenter. So I would like to formally welcome Dr. James Vondenberg, who is our second speaker. Now, Dr. James Vondenberg is a board-certified physician in internal medicine and rheumatology. She completed medical school at Ohio University Heritage College of Osteopathic Medicine and an internal medicine residency at the University of New Mexico. She then completed a rheumatology fellowship at Cleveland Clinic and was appointed a staff physician at the Cleveland Clinic Department of Rheumatologic and Immunologic Diseases in 2023. She sees a wide array of general rheumatologic patients, but has an interest in ANA spectrum diseases. Dr. Vondenberg sees patients at Cleveland Clinic's main campus, as well as Beechwood Family Health Center. What an absolute honor to have you here with us, Dr. Vondenberg. Welcome. And without further ado, we're going to let you take it away.
Great, thank you. So the topic that we're all aware of is mostly focused on hand and wrist pain and the treatment options. So Dr. Satariano did an excellent job talking about the orthopedic perspective and more mechanical and osteoarthritic causes of pain. I'm going to briefly touch on that as well, just because it also comes to us in rheumatology and because it's really the more common causes of pain and also is often present with rheumatic causes. He touched definitely in depth on a lot of the aspects of osteoarthritic and mechanical pain. I'm just going to go over a little of the anatomy briefly. So looking at the right side of the screen, we're just going to look at the bony anatomy. at the bottom portion of the screen, you're looking at the wrist. You have the radius and the ulna. And then just above it, the carpal bones. And just above that, you're getting into the phalanges. And then where they meet, the metacarpal phalangeal joints. Above that, you're going to get into what are called the proximal interphalangeal joints, the distal interphalangeal joints as well. All of this is to say that my arthritis subtypes affect certain joints, and we're going to talk about that as well, because that affects diagnosis, and then proper diagnosis affects treatment options. And then when we're looking at the left side of the screen, we're looking at the soft tissues, so the musculature and the tendinous structures. This view is the palmar view. If you're looking at the palmar aspect of your hand, so you're looking at the tendinous structures. He spoke about the flexor tendons, which often cause trigger finger. There's also the musculature, like this muscular thenar muscles, and lumbrical muscles that often cause pain for people. So we're going to talk in depth about that later on when I'm talking about rheumatic diagnoses as well. So the more common causes of pain, before you even talk about autoimmune causes of pain, are osteoarthritis and overuse. So people, like he was saying, who worked in labor-intensive jobs, like working in construction or using your hands all day, every day, certainly puts you at increased risk of osteoarthritis in certain joints. Similarly, tendinitis and tenosynovitis, trigger finger, tendon contractures like Dupuytren's contractures, and then compression neuropathies, the most common being carpal tunnel, like he was talking about, and then another one, cubital tunnel. They both present with numbness, tingling in certain distributions of the hand. This is diagnosed based on a good history and examination in the office with a provider such as Dr. Satariano or myself, or a primary care provider. So he also showed you images of the more typical areas of involvement. I'm going to start on the right-hand side. He showed you the CMC osteoarthritis. This is a very typical area of involvement. I would say the majority of my patients that I see complain of this area of pain. Like he mentioned, topicals like Voltaren can be really helpful. Oral therapies like meloxicam, Celebrex, even ibuprofen, Advil, Aleve can be helpful. When I have patients on oral NSAIDs or non-steroidal anti-inflammatories, I recommend routine lab monitoring like CBC and CMP just to make sure that your kidneys are tolerating these things. But long-term, it's okay so long as your kidneys are tolerating this. And then steroids can be really helpful when you do a local steroid injection. And I totally agree with him that so long as it's giving you relief, doing this every few months is totally reasonable. The other side of the screen, at the most distal aspect of the joint, so further out along the hand where you're looking at the arrows, this is a really severe form of osteoarthritis referred to as erosive osteoarthritis, which is a destructive form of osteoarthritis. This is something that is treated just similarly to all the things that I mentioned, but actually is a type of osteoarthritis that causes more severe damage to the joints. So I'm not going to spend too much more time on the mechanical and osteoarthritis subtypes of joint pain. I'm going to switch gears into the rheumatologic causes of joint pain. It sounds like in the registration, there were a lot of questions regarding treatment options. So I'm going to use this as an opportunity to address treatment options in rheumatic diseases. We don't have the time to go over all of the possible causes of hand and wrist pain or joint pain for that matter in rheumatic diseases, but we are going to discuss rheumatoid arthritis, seronegative spondyloarthropathies, systemic lupus or lupus, and crystalline arthropathies, including gout and pseudogout. So this is a schematic that I borrowed from a clinical pharmacist in our department because I think it's a nice representation of what we use to describe inflammatory arthritis, meaning you can have an autoimmune process like the diseases I mentioned, like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and lupus. But lupus does not tend to be as inflammatory of a process as rheumatoid, for example. Rheumatoid arthritis and psoriatic arthritis, for example, tend to be more of an inflammatory and destructive process to the joints. These diagnoses have their own criteria. I'm not going to go through the diagnostic criteria for all of these, but so as to say, when you're diagnosing these, rheumatoid has its own serologies, its own antibodies. So the anti-CCP antibody and the rheumatoid factor are helpful in diagnosis, but there is a subtype called seronegative rheumatoid that tends to look and behave just like rheumatoid arthritis, but they don't have the antibodies. Whereas psoriatic arthritis and ankylosing spondylitis are very inflammatory in nature, but they don't tend to be symmetric in the way that rheumatoid is. So rheumatoid arthritis tends to behave symmetrically in that both hands will be involved in the small joints, these MCP joints on either side, or the PIP joints along here on both sides, or the wrists on both sides. Those are typical joint involvements for rheumatoid, whereas psoriatic arthritis and ankylosing spondylitis tend to involve one wrist or one elbow, one shoulder in a non-symmetric fashion. The other component to psoriatic arthritis and ankylosing spondylitis is spine involvement, particularly the sacroiliac joints, so where your sacrum and your low back meet. There are certain findings that are typical, usually by imaging, but can also not be present on imaging, in which case you would consider getting an MRI, and you would usually see it in that case. There are no antibody testing for psoriatic arthritis or ankylosing spondylitis, which is why they're termed seronegative. There is gene testing, but this gene is not specific to these diagnoses and is present in the general population, so oftentimes it's not tested. So things that can be really helpful in the diagnosis of these inflammatory arthropathies are plain films. So looking at the top left corner is an example of rheumatoid arthritis. Looking at the joints I just mentioned, these what are referred to commonly as knuckles, the MCP joints, you see destruction in these joints involved, as well as what's called periarticular osteopenia. So there's actually bone loss around that area. And then you can also see crowding of the carpal bones. You're losing the space around those joints. To the right of it is actually a patient with lupus. You don't tend to see destruction of those joints. You see what's called Jacquard's arthropathy. It's tendinous laxity. So you see the joints tend to deviate, not because there's damage to the joints, but because of a laxity of the structures supporting the joints. And then the image to the far right is an example of psoriatic arthritis. It's referred to as what's called a pencil and cup deformity, which is usually long-term damage where you get almost, the best way to describe it is kind of this triangular shape of the MCP joint. It usually does not happen here. It usually more typically occurs in the further up joints. But there are typical findings on x-rays that can be really helpful for appropriately diagnosing these conditions. In all of these conditions, you can also see osteoarthritis. So it's important to be clear about what diagnosis you're treating, and do you also have osteoarthritis so that you know what to expect in response to the therapies that you're utilizing for these patients. So let's talk a little bit about the terminology with the treatments that we're using. If any of you have ever been to a rheumatologist or sat in on any of these talks before, you've maybe heard the term a DMARD. DMARD refers to disease-modifying anti-rheumatic drugs. That means that you expect to modify the disease progression. You anticipate stopping progression of the disease with immunosuppression or immunomodulatory therapy. These impact the immune response in these diseases. So these include conventional synthetic DMARDs, biologic DMARDs, and targeted synthetic DMARDs. So let's talk about the conventional synthetic DMARDs. These are the older medications that have been around for quite a while. Hydroxychloroquine and sulfasalazine are considered non-immunosuppressive. So they're immunomodulatory. They do not put you at increased risk of infections, whereas methotrexate and leflunomide and azathioprine do place you at increased risk of infections. I've put azathioprine in parentheses because it's not considered particularly helpful for the joints to some degree, but not hugely helpful. You need to do lab monitoring with sulfasalazine, methotrexate, and leflunomide and azathioprine once a month initially, and then every 3 months once you're stable. You expect to see some benefit from these medications somewhere around 6 to 8 weeks into the therapy, so don't feel disheartened if you aren't seeing immediate benefit. Plaquenil can take up to 3 to 6 months to see the full benefit, so again, don't feel disheartened if you don't feel immediate benefit. These therapies work for the joints outside the spine, not axial disease, so not the sacroiliac joints. They can be used alone or as add-on to other therapies that we're going to talk about. So this is a busy slide. Don't get overwhelmed. We're going to start on the left side. These are the biologic therapies. This is kind of what's new and in vogue and what everybody comes to ask me about when I see them. So probably the most popular drugs that most people ask me about is at the top. These are the TNF inhibitors. They're on every commercial on everyone's TV. These are the medications like Humira, Enbrel, Cimzia, Remicade, Simponi. I've included the brand names because these are the things that you're mostly hearing when you see commercials for them, but the generic names are next to them. The other medications listed include Orencia, rituximab, as well as IL-17 inhibitors, Taltz, Cosentyx, IL-23 inhibitors, Tremfya, Skyrizi, IL-12/23 inhibitors, Stelara, ustekinumab, and then IL-6 inhibitors, Actemra and Kevzara. These all have certain roles in certain diseases. They do not work for all of the diseases I've listed. You have to be cognizant of each patient's comorbidities. So for example, TNF inhibitors have black box warnings for possible malignancies, particularly lymphomas. For rituximab, there's a risk of hepatitis B or C reactivation, so we have to screen all of our patients for hepatitis B and C before starting TNF inhibitors and rituximab. If someone has a history of hepatitis B, we have to start them on hepatitis B prophylaxis before starting these therapies. In the medications, IL-6 inhibitors, these can be used for rheumatoid arthritis, but there's an increased risk of bowel perforation if you've ever had previous diverticulitis or colon perforations. So there are a lot of caveats. And when we complete a history, all of these things will come up. All of these medications are true immunosuppression, so they all put you at increased risk of infection with certain infection incidences in each subtype. They are all injection formulation or infusion. Each are dosed differently, either weekly, every other week, monthly. Rituximab is dosed as day 1 and day 15 every 6 months. In the rheumatoid trials, you start to see benefit around 4 weeks, somewhere around 8 weeks in rituximab. So the thing I want you to take away from this slide is just kind of everything I said, in that all the decisions we're making are made in conjunction with what is your diagnosis, what are your comorbidities, what is the main goal. If you have psoriasis, is your skin the major issue? Are your joints the major issue? Is the spine the major issue? Do you also have inflammatory eye disease or gut involvement? So all of these things come up in a visit. So we're going to switch to the targeted synthetic DMARDs. So this mostly refers to JAK inhibitors, although this also technically includes apremilast, which is also used for psoriasis and technically Behçet's. JAK inhibitors we mostly use include Xeljanz and Rinvoq. These are also truly immunosuppressive, but the thing that most patients really prefer is that they're oral therapies. You start to also see benefit very quickly in about 2 weeks, and these are effective for the spine. The major thing is that there's a black box warning for increased risk of heart-related events, cancer, and blood clots. So I don't tend to use this in patients over 65 years old or anyone who has had a previous heart attack or stroke. But obviously all of this is a risk-benefit discussion. There is some increased risk of bowel perforation in anyone who's had a previous diverticulitis episode or colon surgery as well. So I also just briefly want to talk about lupus. This is not very inflammatory amongst the arthritis subtypes we treat. Patients can have, a very inflammatory presentation, but I would say that that is usually the exception to the rule. It is technically within the criteria of the diagnosis of lupus that it would present with a synovitis, meaning true inflammation in the joints. But most lupus patients tend to present with arthralgias, meaning joint pain without profound synovitis or inflammation in the joints. The treatment options for lupus include multiple of the things that I just mentioned, which include Plaquenil, sulfasalazine, methotrexate, leflunomide, azathioprine. Mycophenolate and cyclophosphamide are also utilized in the treatment of lupus, but those are not targeted for the joints. The other medications which are utilized for lupus include Benlysta and Saphnelo. These are newer medications. The Benlysta is a monoclonal antibody that reduces activity of B-cell mediated immunity through the inhibition of B lymphocyte stimulator. Is available as an injection or IV formulation. This is considered pretty effective for the joints, for the skin, and for kidney involvement. It's either weekly injection or IV formulation, which is nice, especially if people have difficulties with adherence to medications where you just have a hard time taking weekly injections and would prefer IV formulation. And then the other option is Saphnelo. This is an interferon receptor antagonist. It's only available in IV formulation. It's very effective for cutaneous or skin manifestations in lupus. However, it unfortunately wasn't very effective for the joints in the studies. That's not to say that it hasn't helped patients I've had with the joints. It's just that in the studies, didn't have the most efficacy in the joints. So the last point I want to make is for crystalline arthropathies or gout and pseudogout. This is not an autoimmune process. This is an inflammatory arthritis caused by the deposition of crystals in the joints. Even though it's not autoimmune, it's very profound and destructive. Gout refers to monosodium urate crystal deposition. Pseudogout refers to calcium pyrophosphate deposition. don't have to remember that. All that to say is that the treatment is different based on the crystal. Gout responds to urate lowering therapies because of the crystal. Pseudogout does not. Urate lowering therapies you've probably heard of include allopurinol if you have any family member with gout. It also includes febuxostat, probenecid, and a really fancy new medication called pegloticase, which is extremely effective but very costly and hard to get approved by insurance. The other options utilized in the treatment include colchicine, NSAIDs, anakinra, which is a daily injection but very effective in preventing flares, canakinumab, which is a monthly injection, steroids. I've put this in parentheses because ideally you try to avoid using this long term because it causes other side effects, but can use it short term. Pseudogout, you can use colchicine to prevent flares, but it's not a good, it's not entirely effective at preventing flares. It can just help to some degree. NSAIDs, anakinra can be very helpful, and steroids, like I mentioned before, not a great long-term treatment option. The image on the right is just to demonstrate the amount of burden from tophaceous gout, and that this isn't just causing destruction of the joint spaces, but also the tendons and the soft tissue. And this is a really profound disease process that I think just doesn't get the amount of attention that it's really due. And I actually very much enjoy treating this as well because I think it can make a big difference in people's lives. But this is my last slide, I believe. Yes, and happy to take questions.
Thank you so much, Dr. Vondenberg. That was fantastic. Wow, absolutely fantastic presentation. At this time, we're gonna, oh, there he is. We're gonna welcome back Dr. Satariano. Just a couple of points here. We just sent out an offer. If you would like to schedule to see one of our presenters today, we strongly recommend that you hit the schedule now option. Now, what that's going to do is it's going to send us here at the Cleveland Clinic a note saying that you would like to schedule an appointment. The only thing that we do ask you to indicate on here under messages is that if you would like to see, orthopedic or rheumatologic. So if you could just distinguish which presenter you'd like to see when you are filling in that form, that would be very helpful to us. And then somebody from the Cleveland Clinic will go ahead and give you a call. So that is just to go ahead and schedule here with us. And then with that being said, I would like to actually just go ahead and start with our first question. And Dr. Vondenberg, I'm going to ask this to you and I'm going to pose this to you is, how would someone know if they need to see a rheumatologist or an orthopedic specialist? What is the distinction and where should someone go if they're having pain?
Oh, that's a hard question. I would say you're not wrong to see either, and that we could probably help you in the visit determine that. Because part of the history that we get is differentiating inflammatory pain from mechanical pain. So when I'm asking questions about joint pain, part of the questions I'm asking is it better with use or is it better with rest? Mechanical pain is usually better with rest. So you say, oh, my thumb's killing me, but if I give it a rest, it gets better. That's more typical of mechanical or osteoarthritic pain. Rheumatoid, as they use it, it starts to feel better throughout the day.
Gotcha. Okay. And Dr. Satariano, is there anything you'd like to add to that as well if somebody is trying to decide? Or you'll both send them in the right place eventually, or what would you recommend?
Yeah, I will say that I speak regularly with my rheumatologic colleagues as well. So we're in close communication because there is overlap here. Mm-hmm. So the most important thing is just getting in the door, that one of us can see you, and then between the two of us, we can sort you out.
Mm-hmm.
Thank you very much for that. The next question I want to ask is to you, Dr. Satariano. Why is hand pain most prevalent in the morning is the first question. And then second of all, what would you recommend exercise-wise that somebody could do when that pain is the worst in the hand and the wrist in the morning to maybe alleviate some of that pain and kind of regain some mobility in the wrist or hand?
Mm-hmm. So kind of like we spoke about with carpal tunnel and trigger. When you're sleeping all night long, a lot of times you're sleeping with those wrists flexed, your fingers flexed. And so if you have a little bit of carpal tunnel, it's going to show up because the nerve has been flexed all night long, right? During the day, you're not sitting there with your wrists like this all the time. So that can aggravate it overnight. Same with trigger finger, where you kind of keep most people sleep a little bit with a balled fist. And so you can worsen the trigger all night long, and that's when they wake up with some mechanical symptoms. I think the most important thing when you get up in the morning is some nice warm water to put your hands in, start to soak them, and start to get them moving again and warm them back up. I found that a lot of patients get relief from that because they are stiff and sore in the morning. And so waking up, some warm water, some stretching, some movement, making that fist, spreading them wide, that can all help.
Perfect. Thank you very much. I did not know that. That's the first time I've heard that about warm water. So thank you for that wonderful piece of information. The second question that I want to pose to Dr. Vondenberg is in regards to an anti-inflammatory diet. Is that something that in your expertise has been proven to lessen the swelling in knuckles for specifically osteoarthritis?
Yeah, I get that question a lot. I don't think that there's great evidence behind dietary changes. However, there are some studies that are saying ultra-processed diets put people at increased risk of later developing autoimmunity like lupus and rheumatoid arthritis. And then there's some like anecdotal evidence for eating Mediterranean-based diets and plant-based diets. And I've had a lot of patients swear by glucosamine and turmeric. So I can't say that there's evidence for these things, but I can say that anecdotally patients tell me they have benefit. I wouldn't say to spend thousands of dollars on supplements because these things aren't regulated. I would say to do your best to eat plant-based diets as well as you can within the confines of your finances. I don't think you have to spend thousands of dollars on all organic. I think that you can do as best you can within eating fruits and veggies and as whole as you can without spending thousands of dollars on supplements. And I hope that answers your question.
That is perfect. Thank you. Thank you very much. And it can be very cost prohibitive to, to spend on those supplements. So thank you very much for that. The next question I want to ask to both of you, and this is kind of a question that we receive for our events often, and I'm wondering if you are getting the same question in both of your offices. So I'm going to actually pose this to both of you. Do you recommend the topical or edible cannabis for relief?
I'll let you go first and I'll follow you.
All right. I get this question sometimes. Topical actually, especially in the hands, where there's not a whole lot of distance between the skin and the joints. If the topical helps, go for it. I have no problem with that at all. Honestly, in terms of the edible either, people will ask, and really, it's not that big of a deal to me. If that helps your pain and it gets your hands moving, allow you to do the activities that you want to do safely, I don't have a big deal, big problem with it.
Mm-hmm. I think that's very fair. I think if you get relief from the topical, I would start with that because then at least you're limiting any potential interaction between any other medications you're on. And then I'm assuming like CBD, not THC, nothing but THC is in the question.
We don't have that specifically in the question. It's more just kind of general cannabis use.
Just because there is some increased risk of heart attack, stroke, like cardiovascular, even with even like edible THC. So I would say that the CBD topicals are probably very safe. Overall, I agree with everything that Dr. Satariano just said.
See, it's good we have a medical doctor on the call here because I just see it as not being a contraindication to operate. So,
sorry?
I said I see it as not being a contraindication to operating. Like smoking bothers me. So So it's a good thing we have you on the call.
It's socially, I have no concerns. Just want to make sure it doesn't interact with meds, and don't want to tell them anything that increases their cardiovascular risk factors or anything like that.
And I'm assuming that would be very important when someone meets with you to really disclose that, to share with you any kind of use. It would be really important. I'm assuming, is that correct? For your treatment plans, to know if there is any kind of use of an edible or a topical, just in case there's like a contraindication.
It does interact and limit the efficacy of a lot of the immunosuppression. So I try to make it clear that I have no judgment. It doesn't bother me from a social construct. It just helps me make decisions about dosing and safety.
Good. Perfect. Thank you very much. I know that can be a little tricky of a question, so I appreciate both of you answering that. The next question that I would like to ask is, again, a question for both of you. How does somebody with Ehlers Danlos Syndrome, how would that affect either of the treatment plans for both of you? Or would it affect it for you?
So I haven't actually had anyone with Ehlers Danlos and an inflammatory arthritis yet. I'm sure it happens, but I haven't had anyone have both like rheumatoid or lupus and a hypermobility. But usually with hypermobility syndromes, the management is mostly physical therapy, because you're trying to strengthen the musculature around the joint to prevent the person from using their hypermobile joint in that way. Essentially, you just don't want to use the full range of motion of a hypermobile joint to prevent early degradation of the joint.
Yeah, we talked about this a little bit with thumb arthritis. People who are ligamentously lax have an increased risk of developing arthritis because their joints lack inherent stability. And when you have less stability in your joint, you increase the contact forces. It's like the ball sitting in the cup doesn't stay in the cup. The ball bounces to the edges, it bounces around. Sometimes it gets onto the cup lip. When you're doing that every single day, your entire life, you can beat up the joint a lot more than if the ball just stayed right in the cup. So when it comes to thumb arthritis in somebody with Ehlers Danlos, I have to adjust my surgery a little bit to make them even more stable. So it does matter with the surgery.
Perfect. Thank you very much. The following question that I have is actually also going to be going to you, Dr. Satariano. This question is kind of specific, so I'm just going to read it as is. It says, when I have come off my anti-inflammatory medication, usually for surgery, my hand hurts very bad. So if for some reason I can no longer take and continue to take that anti-inflammatory medicine, particularly before surgery, what other options does this person have?
So before surgery, you're saying?
Yeah, like to stop taking that anti-inflammatory medication.
So sometimes it depends where the pain is and what's actually the root cause. But a lot of my patients see occupational therapy, and they can work with them on certain therapies. Sometimes that's stretching regimens, sometimes that's specific exercises, sometimes that's specific brace wear that can assist manage that pain long enough for them to get to surgery, and then hopefully after the surgery, get back on those medications.
Perfect. Thank you very much. Now I'm going to ask, again, I'm going to pose this question to both of you. Is osteoarthritis in fingers and toes, which are obviously smaller joints, different from arthritis that you would see in our bigger joints, such as our hips and knees?
I think it's the same process, the same pathophysiological process, to my knowledge.
I agree, for sure.
Good to know.
Yeah.
Thank you very much.
There are different treatments for it. So the smaller the joints, the more likely you are to fuse them as opposed to try and replace them, right? Big joints, shoulders, hips, knees, those can get replaced. The small joints, like little toe joints or the very, very end of the finger joints, we tend to fuse those joints to treat arthritis rather than replace them.
Gotcha. Okay. This question I'm going to pose to you, Dr. Vondenberg. What does inflamed red knuckles indicate to you? And are skin rashes such as that indicative of a certain type of arthritis?
Yeah, so this is where exams are really helpful too, because oftentimes when people say knuckles, they mean here. This is the MCP, but knuckles could also mean the PIPs. I've even had people mean the DIPs. And what I was saying earlier is that each joint has associations with certain inflammatory arthritis subtypes. So it kind of depends on the joint involvement. What does the joint look like? What does it feel like when I'm pushing on it? When is the joint inflamed? Is this episodic? Is it after they're going to Red Lobster and eating a bunch of shrimp and lobster? And is this more gouty, or is this happening all the time and it improves with activity? So it could be that they have a crystalline arthropathy like gout or pseudogout, or they could be having psoriatic arthritis. So that's a scenario where they need to come in and see a physician and have an exam and a history.
Perfect. Thank you very much. My next question is to you, Dr. Satariano. So with a severely arthritic ring finger that injections have not helped, would the surgery to repair specifically this ring finger be similar to that of the thumb surgery that you had described in your presentation?
Good question. Thumb arthritis surgery is inherently different from the rest of finger surgery. So it depends on where that ring finger is injured or is arthritic, right? This knuckle, is it the PIP, is it the DIP? At the DIP, that's the furthest one, the little guy out here, we tend to fuse that. If it's at the knuckle joint or right here at the PIP, that is a discussion, either a fusion, or sometimes we can replace those joints. But it's a little tricky because unlike hip or knee, those joints do not hold up very long. So if you are 50 years old and you intend to continue working your heavy manual labor job, I would not do a knuckle joint replacement because it will not last the rest of your life. I'd be more inclined to do a fusion. So it is A, inherently different than the thumb surgery, and B, very dependent on both the patient, their occupation, and the specific location in the finger.
Wonderful. Thank you very much. The next question I'm going to ask is, actually, I'm going to pose this again to both of you. How would someone know the difference between carpal tunnel and arthritis? What are there key identifiers that somebody can kind of address at home? Or is this something, again, that would really require somebody to be seen in your office?
Probably both. So it's pretty easy to know you have carpal tunnel usually. The distribution is usually along these first three fingers from the palm. It's usually pretty apparent to people, usually waking up with it like Dr. Satariano was saying, but it's often present as an initial presenting factor in inflammatory arthritis, particularly rheumatoid arthritis. However, caveat being that it's also just really common in the general population. But it's totally reasonable and fair to either see your primary care doctor first about it and try wrist splints and sleep with them at night and see if that resolves it. And then if it's not resolving it, escalate to seeing ortho.
Yep. It is numbness. If you're having numbness in your hand, that's when I think carpal tunnel. That's affecting a nerve.
Okay.
Whereas if you're having pain more with use and loading the wrist and fingers, that's when I think more arthritis from the grinding bone on bone. The nice thing is when you come and see us, an x-ray will tell a lot of the story, because if you just have carpal tunnel, an x-ray tends to be normal. Whereas if you have arthritis and you get an x-ray, you tend to see significant degenerative changes at the affected joint.
Perfect. I'm going to ask you a question that I just kind of want to pose to both of you. We are all on our phones. I think every single person is just constantly scrolling, or just the way we hold our phones. Is this something that especially in recent years, have you seen an increase in injury to thumb or index finger? And what do you recommend for everybody that is just constantly on their phone?
I'll let you go first. This is your domain.
Okay. Yeah, so I will say it's more, I'm going to kind of loop this into the repetitive strain category.
Okay.
So sometimes I see patients who come in who are, for example, coders, and they are typing all day long. They get some vague tendinitis type pain that a lot of time responds to changing the ergonomics of how they're sitting, and as well as some occupational therapy. This would fall into that category of a repetitive strain, a little bit of a tendinitis. Sometimes it manifests as Decker veins, which is pain with thumb use, specifically extending your thumb a bunch. So when I see it, it tends to be more of a tendinitis type pain, which, just like a tendinitis, it responds to rest, put the phone down, and a little bit of non-steroidal anti-inflammatory.
Great. Thank you so much. Is there anything that you'd like to add, Dr. Vondenberg?
I text like an old lady. That's all I got to add. I agree with everything he said.
Perfect. Now I want to ask this question for you. Hyaluronic acid, is this the same thing as cortisone? And speaking of cortisone, can you have too many injections in your hand?
I'll save my part, but then I think his insights might be more helpful. But they're not the same. Generally, we do not do steroid injections more than every 3 months, because there's the potential to degrade the joint. You could do some harm to the cartilage lining the joint. The lidocaine in and of itself can also cause some issues with the joint. But you can do injections every 3 months if it's giving you benefit. If somebody's in their 70s and knee injections are giving them relief every 4 months, that's very reasonable. If they stop working, you can also do hyaluronic acid injections. I think in most of the studies, the hyaluronic acid injections were not considered superior. Although, is that true? I don't think there was any superiority.
No, I completely agree with you.
But I'll let you go from there if you have any other 2 cents about that.
Yeah, it's they are different. One is not definitively better than the other. You're welcome to try either one.
Mm-hmm.
At least for the thumbs, we tend to just do steroids. The hyaluronic acid has not been shown to be as beneficial as, say, in the knees. So it's usually a steroid, and just like Dr. Vondenberg said, I typically would only do it once every 3 months. It can damage the cartilage. That being said, some people already have end-stage arthritis where the joint is completely shot. And so if I can inject them to prevent the surgery, I will inject them all the live long day, because I'm not going to do any more damage. The damage has already been done. It's okay.
Perfect. Thank you so much. And actually, you know what? I think that's going to wrap up our Q&A segment here. We could probably sit and ask you questions all day long, but obviously we want to be mindful of everybody's time. So I want to thank you so much for participating in that Q&A. And again, thank you so much for both of your presentations and for your time today. Again, for those who are watching, please feel free to send us a message if you would like to see one of our 2 physicians here. If you'd like to see them, go ahead and send us a message. Just indicate which one you are looking to speak with, and we will have somebody from the Cleveland Clinic go ahead and give you a call. So I want to let you know what is coming up next. In about 24 hours, so from this recording, so tomorrow, you're going to be receiving an email just as you had from the invitations and the reminder for the event, letting you know that this recording is now available. So this recording in its entirety is going to be emailed out to everyone. You will have it. You can go back. You can listen to some of the parts that maybe you missed when you walked away, or of course you can share it with friends and family. So please know that you will be receiving an email with this recording in its entirety. And then again, as mentioned, the handouts that are on your right-hand side are also going to come along with that recording. So if you'd like to take a look at some kind of helpful information that we have shared in that handout section, and of course from our partners at the Arthritis Foundation as well, we have some really great information from there as well. Here are some additional resources. You can scan the QR code if wanted. But again, these pieces of information are going to be found in your handouts. And on behalf of everyone here at the Cleveland Clinic, as well as our partners with the Arthritis Foundation, we would like to thank you all so much for your time today. Thank you, Dr. Satariano, and thank you very much, Dr. Vondenberg. We appreciate your time, and I hope you all have a wonderful rest of the day.
Thanks, guys. See you.